Hi guys, I'm Brandon Ayres from the Cornea Service at Wills Eye Hospital and Ophthalmic Partners of Pennsylvania. And today I wanted to talk to you about an IOL exchange. And nothing crazy, but I get a lot of questions about just how do you do your basic lens exchange. And a lot of my videos show very complicated exchanges with vitrectomy, but what if it's just in the bag to in the bag? So what I wanted to do was invite you guys to come with me into the operating room, take a seat, and let's watch a standard IOL exchange. So the short story for this patient is they were unhappy with their quality of vision with a extended depth of focus lens and had some residual astigmatism. So we're going to exchange for a new toric IOL. Now, whenever I'm doing a lens exchange, I always make 3 paracenteses, one superior, one inferior, and one nasal, and that really helps make sure I can get access to all the way around the lens for viscodissection of the capsular bag. One of the most critical parts is how do you get underneath the capsular bag? I like to use a micro grasping forceps, but there are lots of ways to try and get the anterior capsule to lift off of the IOL. So although I said I was going to use a micro grasping forceps, this is actually a Snyder grasper. It's an atraumatic forceps, 25 gauge, and I'm using it like a shoehorn to carefully lift up the capsule and then put OVD underneath. Now, really be careful. Whenever you're adding OVD, make sure you release a little bit through the main incision. That way you don't overpressurize the eye. That's one of those little tricks that we often don't even know that we're doing. If you pressurize the eye too much, you can end up with iris prolapse and all kinds of problems. So whenever you're going to add OVD to try and inflate the capsular bag, let a little bit out first. Now, I'm having a little bit of trouble here getting some of the capsular fibrosis to release along the haptic-optic junction. And I'm having a hard time kind of pulling the lens because, the whole lens moves together. And you can see that terminal bulb out there is still fibrosed in, which is a really common spot for fibrosis with this lens platform. So what I figure we'll do is let's just amputate the haptics. This is going to do a couple of things. One, I suppose you could just leave the haptics in the capsular bag if you wanted to, but my goal was to add some surgical angles that I didn't really have while the optic was still in place. So we're going to amputate both of the haptic-optic junctions, and now the optic is free. Now, if you guys watch any of my videos, you know that I love to cut IOL, so I'm using the scissor. This is a Packer-Chang IOL cutter. I'm using it like a forceps and a scissor, kind of handing myself, see right here, kind of handing myself with the micro holder the IOL, and then we'll cut across. And I usually cut my lenses into 2 or at least 3 pieces, sometimes more. And I do that so that I can not traumatize the wound taking it out. There you saw again using the scissor like a forceps. You can use it. You got 2 instruments, you might as well use both of them. Now we have all of the optic out of the eye, and see, this gives us the ability to use a bimanual technique with angles we didn't have before to free up those haptics. This doesn't work in every single case, but it worked beautifully in this case. So once again, see, I can hold on to the haptic, and now I can take OVD and just push it right down the little cocoon where the haptic is sitting, and you'll see it release all the way down the haptic, including releasing the terminal bulb. So this bimanual technique is really, really critical when you're doing IOL exchanges, especially when the lens has been in the bag for a period of time. Now we're ready to put the IOL back into the capsular bag. Now in this case, we're also going to be placing a toric IOL, so it's really important that the capsular bag is completely opened, especially where the haptics are going to land for placement of the toric lens. And this may be different from where the haptics were from the previous IOL, so make sure that capsular bag is completely opened with OVD. So I've already done that. I've made sure my capsular bag was open all the way around, again using all 3 of those paracenteses and the main incision, and that allows me to get this toric implant in the eye right on axis. And you can tell the capsular bag is open because the haptics are fully released. Now sometimes what you'll see is one of the haptics maybe is creeping into view, or you can see that it's not fully extended, and that means that the capsular bag hasn't been open. So you have to work in that little quadrant a little bit longer to release any capsular fibrosis. Now that the lens is in, we're going to kind of hold it back in place while we do our IA to get any retained viscoelastic out. And then all that's left is just make sure it's on axis, and we'll seal up our incisions, make sure everything is watertight. And usually you don't need any stitches for these, but I don't like to leave anything leaking. So if anything seems to be just a little bit leaky, we're going to put a 10-0 nylon. Here, everything looks great, and our lens exchange is completed. All right, guys, well, thank you so much for joining me. That is the standard IOL exchange, and we'll show more complex stuff later. Hopefully you've seen something in this video that you can apply to your own patients to help them see better. Thanks for watching.